about both medical and surgical management of feline and canine mammary carcinomas. I will be focusing on the canine mammary carcinomas. So I will start with a very brief introduction, just going through the topics of my presentation. We will be discussing about a little bit about pathogenesis, predisposing factors, what type of investigations, the type of staging that we need to do for canine and feline mammary carcinomas, how, for example, the grade and the histological subtypes of canine mammary carcinomas that can affect local recurrence and the risk of metastases, what prognostic factors, what poor prognostic factors we can see in our histology reports, and for example, about treatment options. Henry will be focusing on the surgical part, which of course is paramount.
See you. That's fine. It's okay. Sorry,
no, that's all right. Henry will be focusing on the surgical part, which is paramount, and I will be discussing mainly about a few bits about chemotherapy, about hormonal therapy, and the benefit of ovarian hysterectomy. So regarding epidemiology, of course, we can see increased frequency in intact females. That's something that is quite a common problem in Sweden or other countries like Denmark, because there are not many spayed females, and we have estrogen and progesterone-induced tumors. Of course, exogenous use of progesterone, as you can use, they can predispose to mammary cancer, older patients, and obesity. Now, depending on the study, we can see that the mammary cancer in dogs, most of them, they can be benign at between 60 and 85%, and the malignant, they can be between 50 and 40%. Again, that depends on the study. Sometimes it can be up to 50% basically. Now, regarding the predisposing factors and the pathogenesis, of course, it's well known that in human oncology, in women with breast cancer, BRCA1 and BRCA2 mutations, so mutations that we can see in DNA repair enzymes, they predispose to mammary cancer. That is something that the last probably like 5 to 10 years, it has been investigated in veterinary oncology. It has been seen in some breeds like English Cocker Spaniel, possibly in German Shepherd dogs. So it's something that slowly it's introduced as a concept in veterinary oncology. Also predisposing factors, as we said before, the hormonal effect. I'm sure you all have heard that spay before the first, second, or third estrus can decrease substantially the risk of mammary cancer, and we can have patients that they have a risk between like 0.5% to 26%. Now, we have to bear in mind that the hormonal effect usually predisposes to mammary cancer that they have a high concentration in estrogen and progesterone receptors. In general, these might be considered less aggressive compared to other mammary cancers that they have either BRCA mutation or HER2 mutations or other types of mutation. But that's, of course, the hormonal effect is quite strong. So it's something that we should be aware. Other risk factors, of course, increased body weight, and of course, the predisposition like English Cocker Spaniels and German Shepherds. So when we're discussing about mammary tumors and more specifically about mammary carcinomas, what is the common biological behavior? So what's the pattern of metastasis? Of course, mammary carcinomas, we're talking about epithelial tumors. So most commonly, we will be seeing neoplastic cells causing metastasis to the lymph nodes, secondary to the pulmonary parenchyma. And in some cases, we can see some metastases to the bone or to other visceral organs. Now, on the next slide, you will see, it's a bit of a busy slide, but it's a nice picture on the right-hand side from Miller's anatomy. So that's a picture that shows the lymphatic drainage in the one side of the mammary glands. So even though it is considered that, for example, the front mammary glands, they only go to the axillary lymph nodes, or the back mammary glands, they only go to the inguinal lymph nodes, we can clearly see in that picture that, for example, the first mammary gland, it can mainly go to the axillary, but the second, third, or fourth, they can easily go to both the axillary and the inguinal lymph node. And also you can see that between the fourth and the fifth mammary gland, there is some lymphatic connection that it is not consistent, but if that happens, potentially the fifth mammary gland, in theory, could potentially go to the axillary lymph node. So that's important when we are discussing about the staging. And of course, we have to take samples from as part of the staging, to take samples from the lymph nodes, we have to bear in mind that if we have a mammary gland, let's say the fifth mammary gland that is affected, doesn't necessarily mean that the inguinal lymph node is the only one that could be affected. And also something that it has been reported, there are studies about lymphatic drainage in mammary tissues. So we can see that there is cross connection of the lymphatics between the left and the right side. So something also to bear in mind when we are performing staging for mammary cancer. Now, regarding the type of investigations, so of course, full biochemistry in hematology is something that we commonly do in our patients. There are cancer patients, where they have a chronic disease, but also there are studies that they can rarely report some paraneoplastic syndromes like neutrophilia, potentially hypoglycemia, hypercalcemia, or hypoalbuminemia. So it's something to bear in mind when we have a patient with mammary carcinomas. As part of the staging, of course, it is essential to perform thoracic imaging. Of course, there is always a debate between CT scan or thoracic radiographs. Of course, thoracic radiographs, it's something that's commonly used in general practice. It's actually a very good tool. It's a good screening tool. So I think it is more than good enough. Of course, with a CT scan, we have it's a more sensitive. We can detect smaller lesions. So it's also something, it's more and more frequent to have a CT scan in general practice. So of course, it's something that you can consider using when you have mammary cancer in dogs. And of course, abdominal imaging. The abdominal imaging, it's mainly not for the visceral organs because it's not that common that we have metastatic disease in visceral organs, but it's mainly for comorbidities. We are dealing with older patients, so having comorbidities, of course, it is quite common. And also doing abdominal imaging is also going to help us to assess the lymph nodes, the axillary and the inguinal lymph nodes. And also sometimes when we have a primary mammary tumor, sometimes we can see some small nodules that because they're in the subcutis, we cannot easily palpate them. So by doing advanced imaging with ultrasound or CT scan, we can see smaller lesions that they potentially need to be resected and not just the primary, very obvious mass. So on the next slide, as we discussed, as part of the topic, we will be mentioning which factors they can affect, they can impact on survival. So with mammary carcinomas, of course, there is a grading system. There is a study in 2017 from which I have borrowed these Kaplan-Meier curves. We can see that there is a substantial difference in survival after surgery alone between grade 1 and grade 2 mammary tumors and grade 3 mammary tumors. Of course, we can see that based on that study, at least, and that Kaplan-Meier, that the median survival of grade 3 mammary tumors, like high-grade mammary tumors with surgery alone, is around 6 months, while for grade 1 and grade 2, the survival is much prolonged. Of course, sometimes things with mammary carcinomas, they can get a bit complicated. It's not just about the grades, and we'll be discussing in the next slides. There are studies about the subtype playing a substantial role in mammary carcinomas. You can see on the right-hand side, there is a table that, for example, shows us the different histological subtypes. So from the least aggressive, which are the complex carcinomas, to the more aggressive, which are the anaplastic carcinomas and the carcinosarcomas, we can see that there is substantial difference in survival, with a 1 and 2 year survival for complex carcinomas being almost 100%, while with carcinosarcomas, the median survival time is between 3 and 4 months. So there is a substantial difference. So on the left-hand side, you can see the Kaplan-Meier that correlates with that table. You can see that with that arrow, that's the survival curve for the complex carcinomas, while for the anaplastic and the carcinosarcomas, the survival and the Kaplan-Meier curve is much, much worse. Of course, apart from the grade and the histological subtype that play an important role, there are other poor prognostic factors. We have the tumor size, we have the lymphatic involvement, and the WHO classification. There are many studies that they focus on the tumor size. However, the tumor size can be quite subjective in a way. We're dealing with different body types. Our patients, they can vary from like Chihuahuas to like Great Dane. So tumor size, yes, it is prognostic, but obviously it depends on the size of the patient. So regarding the importance of the tumor size and the WHO classification, that is a table where we have the staging system that we use for mammary tumors. We can see, of course, between stage 1 and stage 2, the what is actually important is the tumor size. But again, we said that, that can be subjective, but also what's important is the growth rate of the tumor, ulceration sometimes, but it's not something that's been consistently reported as a prognostic factor. And of course, in stage 4, we can see that we have the presence of an affected lymph node, which also affects prognosis. And of course, so in stage 4, and of course, in stage 5, we can have a pulmonary metastasis. Now, we discussed before about the lymphatic invasion as a prognostic factor. So that is a Kaplan-Meier curve that I took from one of the pathology studies regarding mammary tumors. We can see clearly that on the curve that is the blue curve, where we don't have any lymphatic invasion, the difference in prognosis is actually quite substantial compared to when we have lymphatic invasion. Of course, in that study, that difference is based on just using surgery. Of course, that was a study that the point of that study was not to assess how useful is chemotherapy. So we can consider that potentially by using chemotherapy when we have lymphatic invasion, potentially, we could push the curve that represents the lymphatic invasion a bit to the right, so possibly improve the survival. So that's something for you to consider. Of course, we're discussing about mammary carcinomas. We have some very specific subtypes of mammary carcinomas, like lipid-rich carcinomas that we can see in very young dogs, that they can be associated with more aggressive behavior. We can have inflammatory carcinomas like that picture on the right-hand side. And of course, the appearance of inflammatory carcinoma is actually quite specific in a way, because inflammatory carcinomas, they are associated with invasion of the infarction of the superficial lymphatics. So that picture, which has been adopted which I have used from a book, it's quite a typical appearance that we can see. The main problem is that when we have an inflammatory carcinoma, usually performing surgery is not an ideal option, and it's probably one of the very few mammary carcinoma that surgery is not an option. For example, on the right-hand side of the bottom of the slide, you can see that there are some studies that they combine some anti-angiogenic treatment, thalidomide, cyclophosphamide, radiotherapy, but usually these tumors are so aggressive that even with multimodal approach, the prognosis is actually quite poor. For example, in these two studies, prognosis was between 4 to 6 months, even with very involved treatment. So someone could argue whether a very involved treatment is in the patient's best interest, of course. So, inflammatory carcinomas are a different, they belong in a different category compared to other carcinomas. So the next step is, of course, to consider the treatment options. As we said, Henry is going to focus on the surgical management, which is paramount. Now we have to consider, when do we use chemotherapy? So in which case of mammary carcinoma we use chemotherapy. So, for example, if we have a high-grade tumor, if we have a tumor with lymphatic invasion, if we have a tumor that from the histological subtypes, it's actually quite aggressive, like a comedocarcinoma, anaplastic carcinoma, carcinosarcoma, like tumors that have a high risk of metastasis. In these cases, we have to consider chemotherapy. Also, in that table, there is a mention about osteosarcoma. Of course, it is a rare presentation having osteosarcoma of the mammary gland, but from the extraskeletal osteosarcomas is probably one of the most common ones in a way. And of course, as we said before, if we have inflammatory carcinoma, we can use chemotherapy. So effectively, high-grade tumor, lymphovascular invasion, aggressive histological subtype is one of the indications of, and high stage is one of the indications of using chemotherapy in mammary carcinomas. Now, the next question, of course, about chemotherapy is what type of chemotherapy? What is the gold standard of chemotherapy in mammary carcinomas? And to be honest, the honest answer is who knows? Of course, in women, they are very focused in either immunotherapy or targeted treatment, or from the classic chemotherapy, they're very focused on anthracyclines. And many of the oncology clinicians, many of us, we base our decision-making process of using chemotherapy agents based on what is used in humans. So, for example, quite a few of us, they will use anthracyclines like doxorubicin. Other people, they might use carboplatin. To be honest, there is not strong evidence to suggest that the one is better than the other. but usually our first choice is either carboplatin or doxorubicin. Some people, there is a study on the right-hand side of the slide that compared, for example, use of dose-intense chemotherapy plus thalidomide plus metronomic chemotherapy. In that study, they didn't find the significance. It was likely that the study was underpowered. Again, there is some benefit, potential benefit, if you have an owner that you want to give chemotherapy, but they're not keen to give dose-intense chemotherapy. You could potentially give some metronomic chemotherapy. There is not a lot of evidence, but potentially it's something that might help and delay recurrence or delay progression of the tumor. I guess we don't have big studies to suggest that it's going to help, but it's something that you could potentially use. If you have an owner that doesn't want to be referred, you could potentially use metronomic chemotherapy as an option. Now on that slide, you can see a Kaplan-Meier curve on the right-hand side. That was a study that compared carboplatin versus carboplatin and metronomic cyclophosphamide. In that study, they found that using carboplatin and cyclophosphamide gives better results. But to be honest, usually these studies are underpowered. So the honest answer is we don't have a gold standard of treatment, but something between platinum agents and anthracyclines if we want to be aggressive enough in a way. Apart from chemotherapy, we will be discussing very briefly about hormonal therapy. It is something that is commonly used in women, and is commonly used in women, especially for breast cancer that they have a high concentration of receptors like progesterone and estrogen receptors. The main drug that is used in this case is a medication called tamoxifen, which is an estrogen receptor inhibitor. It's something that it was used back in the 90s in veterinary oncology, but usually the side effects were quite substantial. So there were many cases that if the patients were they were not spayed females, they would develop pyometra, they would develop some valvular discharge, some vaginitis. So quite substantial side effects. And to be honest with you, when we send a mammary tissue in the lab, there are not many labs to assess for estrogen and progesterone receptors unless we send them in specific labs. So most of the times we will not know if it is a specific case to use, for example, something like tamoxifen. But in general, it's something that it has fallen out of favor. So, and it's associated with a lot of side effects. So it's not something that is strongly recommended. And next part of the treatment options, ovar hysterectomy. So what is the evidence behind ovar hysterectomy and mammary cancer? Of course, we said at the beginning that when we have a patient that is spayed quite early, that decreases the risk of developing mammary cancer in the future. What we have to consider is that when we have an entire female dog that develops mammary cancer, you could assume potentially that it's a mammary cancer that has a high concentration of progesterone and estrogen receptors. So in theory, by doing a spay at the same time, you are decreasing the driving factor that causes that mammary cancer. So, okay, in that case, you decrease the risk of developing mammary cancer with increased concentration of estrogen receptors, but that doesn't actually reduce the risk of developing in the future mammary cancer that's not associated with increased concentration of receptors, hormonal receptors, but for example, like BRCA mutation or HER2 mutation. So it's something that, yes, you could consider, and of course, you can consider it to avoid developing pyometra in the future, or you can consider it if you have a strong suspicion that is a mammary carcinoma with a high concentration of hormonal receptors to prevent recurrence of the same tumor that doesn't decrease the risk of new type of tumors in the future. So these are the main treatment options that, of course, we utilize as medical oncology. We mostly focus on chemotherapy, and of course, Henry will discuss about the surgical parts in a bit. Shall we do questions now or at the end, or what?
There are any questions?
just saying it's no gold standard. So what is your definitive thing saying these dogs we will treat, these dogs we won't treat? You must have a protocol.
Yes. So for example, if we have a case that it has positive lymph nodes, you mean to treat with chemotherapy?
Yeah.
So we have positive lymph nodes. We have a histological subtype that is not very well differentiated. So we have a lot of necrosis, like carcinoma. We have poorly differentiated cells, like anaplastic carcinoma, for example. So quite aggressive subtypes. If we have clinical features that they are quite aggressive, so quickly growing mass, ulcerated mass, features that clinically they make you think, well, I don't think that is going to be, even if the histology says that is an intermediate grade, clinical is behaving like a high grade on histology, or, for example, like a positive lymph node. Yeah, I think these are the sort of things that, so like some key factors, some things that they will make me consider chemotherapies, lymph node metastasis basically, and a poor histological, a poor prognostic factor, and clinical features that they suggest aggressive behavior, and of course, high-grade tumors. Now, if it is a low-grade tumor, we don't necessarily need, for example, if we have a low-grade tumor, we have a clear lymph nodes, as far as we can tell based on cytology, we don't have an indication to give chemotherapy in that case. You will see on the, actually it's not on that slide, but for example, for a complex carcinoma, which is a very well-differentiated tumor, if it is a low-grade, the risk of lymph node metastasis is probably between 4 and 8%, so it's quite low. If we have an anaplastic carcinoma, irrespective of what grade it says on the histology report, the risk of metastasis can be over 70%. It is a bit of a risk assessment in a way. So we have to, based on that, we have to decide whether we give chemotherapy or not. So if we have poor prognostic factors, I would give chemotherapy. We don't have a test like a liquid biopsy to assess if we have circulating cancer cells. So we have to assume that with aggressive histological subtypes, we have to assume that metastasis is going to happen. So these cases usually treat with chemotherapy. I don't know if that answers your question.
Yeah, sort of.
Sorry, in practice, are we always best to do a biopsy first before we tackle these surgically to see what stage it is?
To be honest, the problem is that cytology in mammary tumors is not always going to give us the answer. The problem is that, if we have a very well differentiated malignant tumor, it can almost look the same as a benign adenoma because the cells are very well differentiated. So cytology, there are some limitations with cytology. Cytology is not going to tell us the difference. Of course, if it is, yes, potentially biopsy, or on the other hand, you can do a very conservative surgery, and then based on the histology, you can do a follow-up surgery. It also depends on the size. Oh, Henry will discuss that.
Yeah, sorry. I got this little just out.
Yeah.
I don't have that actually in my presentation biopsies, but I was just getting keen to say that from a surgical point of view, it's not really going to make a difference to what you do.
Yeah. Okay.
So it would be useful, I suppose, only in the case where the owner would choose not to proceed at all.
Yes.
The prognosis was bad.
Right.
But it's not something we do routinely because we do the surgery and then we find out because the surgery we do the same way regardless of what the histology.
Right. Thank you.
But yes, I think that, to be honest, cytology.
You never know whether you jump in and just cut, or whether especially if you're given an anaesthetic to take the biopsy or anything like that, and then you've got to give it twice. And sometimes they've got comorbidities, they're older, owners have got so many refunds, that's really becoming increasing issues.
To be honest, regarding cytology, I don't think that it's always useful.
No.
Okay, thank you, Costas. Thank you, everyone, for coming. My name is Danielle. I'm one of the other oncology clinicians here at Southfields. So I'm going to be going through the medical aspects of feline mammary tumours. So we'll start with a little bit on the epidemiology and the risk factors of these tumours. It's reasonably similar to dogs. So As a general rule, cats get fewer mammary tumours than dogs do, but they are still the third most common tumour in our female cats. The two most common are skin cancer and lymphoma. The annual incidence is about 12 to 17%, depending on the study that you read. Countries like Sweden, where spaying cats is not routine, have a much higher incidence of around 40%. We do also unfortunately suspect that these figures are an underestimate, because we do know that unfortunately fewer cats are insured than dogs are, and most of the studies that we have come from a referral population, which means, you know, uninsured cats are unlikely to be referred. So these numbers are the best we have, but they're probably a bit of an underestimate. Like in dogs, mammary tumours are much more common in our middle-aged to older cats. The average age of diagnosis is about 10 to 12 years. We do see more mammary tumours in domestic shorthairs, but that just more represents the fact that they're much more common than the purebred cats. There does, however, seem to be some breed predispositions, particularly in Siamese cats. There are definitely several studies that show that Siamese cats are definitely diagnosed with mammary tumours more commonly. They also tend to be younger when they're diagnosed. So, again, like in dogs, the exposure to ovarian hormones early in life is very strongly implicated in tumour development in our cats. So entire female cats have a 7 times higher risk of developing a mammary tumour than a cat that was spayed early in life. Spaying cats at an early age has been shown to be strongly protective. And this shows us that it's the early exposure to hormones that matters. Although there is a long latency period in this, because although we know that's the early exposure that matters, most of the cats are older by the time they're diagnosed. We know it's the early hormone exposure that matters because, again, like in our dogs, you lose the protective effect of spaying quite quickly over the first few years of life. So in cats spayed less than 6 months, there's a 91% reduction in risk. Between 6 and 12 months, it's 86% reduction in risk, and 11% reduction in risk when you're spayed between 13 and 24 months of age. And there is no benefit seen in spaying them when they're older than 2 years. So we do also know that the administration of exogenous progestins is also a risk factor. It's not done as much in these countries, but again, in countries like Scandinavia, where surgical spaying is not really done, though we do know that it's not just endogenous hormones, exogenous hormones matter as well. They have a 3 times more higher risk, but they are more likely to develop benign tumours. Benign changes such as fibroepithelial hyperplasia, which we'll come to in a minute, they can occur quite rapidly, and they're quite strongly linked with exogenous progestin as well, and it can be as little as 1 injection. But it tends to be that you need more regular and prolonged exposure before you develop malignant tumours. Again, male cats, while mammary tumours are vastly more common in female cats, male cats that are administered exogenous progestins can also develop mammary tumours. Okay, just going to go through this quickly. It's mostly what I was just talking about. Mammary tumour risk associated with ovarian hormone exposure early in life, long latency period because they're older when they're diagnosed. In dogs, we know that there's an interaction between sex hormone, growth hormone, and IGF-1. In cats, we suspect it but cannot prove it. We do know that progestin-induced mammary production of growth hormone has been shown. So it's likely, like in our dogs, there's an association between the sex hormones and growth hormone, and that's probably contributes to the carcinogenesis, but we can't prove it. Okay. So while hormone exposure is strongly associated with the early stages of tumour development, unlike in our dogs, most mammary tumours in cats are hormone receptor negative by the time they're diagnosed. Only a third of mammary tumours in cats are shown to be hormone receptor positive, which suggests that while we know that the hormone exposure is important for the early stages, that these tumours tend to lose these hormone receptors as they become malignant. So normal mammary tissue and benign lesions often almost always express hormone receptors, but the malignant ones almost always lose it. And that's associated with their more malignant behaviour. Oops, sorry. Okay, so Fibroepithelial hyperplasia, it's not something that we see very commonly, but it is worth keeping an eye on because it can look quite nasty, but is actually fine. So it's a benign growth that is typically seen in young, entire cycling female cats. It is known to be strongly progesterone dependent. So it's either seen almost exclusively in cycling entire cats or neutered cats that have been given an exogenous progestin. It can be seen with as little as 1 dose. It can look quite nasty. It can be one or multiple growths. It can grow quite quickly, but it's completely benign. It can be cured by spaying or by administering an anti-progestin. There we go. Okay, so unfortunately, benign mammary tumours in cats are incredibly rare, less than 10 to 15%. You do occasionally see them, but it is unfortunately quite rare. So occasionally that you do get adenomas, which can be cured by surgery alone. You can get local recurrence if your margins are narrow, but they're benign, they do not metastasize. Unfortunately, we don't see those very often. Unfortunately, it's much more common than nasty ones. So like I was just talking about, the vast majority of mammary tumours in cats are malignant, unfortunately, between 85 and 90%, depending on the study that you read. There is far fewer histological subtypes than there are in dogs. They are much more commonly to be just simple, so one cellular component carcinomas. So the most common types are tubular, tubulopapillary, or solid carcinomas. But you don't tend to get the mixed types, and there's nowhere near as much variety as there is in dogs. Okay, unfortunately, they are almost universally bad. Like I was saying before, most of them are hormone independent. Most of them don't express hormone receptors, which is equivalent of the more aggressive mammary tumours seen in women. Associated with the absence of hormone receptor expression, they're aggressive. And they can have quite an aggressive clinical course, unfortunately. We know that in women, hormone receptor negative breast cancer is a negative prognostic indicator. Unfortunately, that's also true with cats. These tumours are very malignant. There's high rates of local recurrence if the surgery is not aggressive enough. Having multiple tumours is really common, and the metastatic rates are unfortunately also really high. Again, depending on the study that you read, metastatic rates for these malignant tumours is between about 50 to 90%. Most common is the regional lymph nodes, but you can also get metastasis to the lungs, the liver, and the pleura. So classically, these cats are presented for the mass itself. Classically, older female cat who is either entire or was spayed later in life. Usually presented for the mass itself, occasionally presented for being systemically unwell. If they are systemically unwell, unfortunately, that does tend to be associated with more aggressive disease and can be a negative prognostic indicator, because it usually means they've got quite a high disease burden if they're feeling unwell from it. There is a little bit of disagreement about if all glands are equally affected. There's been one study that states that they are all equally affected, but a more recent study suggested that the cranial glands in our cats are perhaps less commonly affected. Multiple tumours are really, really common. 60% of cats at the time of diagnosis have more than one mass, so we need to check them carefully. And metastasis to regional lymph nodes is unfortunately really common as well, so they need to be sampled definitely. Larger tumours can become ulcerated and painful, and they're sometimes presented for that. The one good thing is cats don't really get inflammatory mammary carcinoma like dogs do. So despite the fact they are definitely more prone to more aggressive tumours, they don't really get the, it's been reported, but inflammatory mammary carcinoma in cats is incredibly rare, fortunately. So staging a feline mammary tumour is pretty much the same as staging a canine one, but because of the higher rates of metastasis, we do definitely recommend sampling both the regional lymph nodes, both your axillary and your inguinal. Might need ultrasound guidance if they're not grossly enlarged. We do also recommend either 3-view thoracic radiographs or a CT. Again, particularly in a cat, thoracic radiographs tend to be fine. You can do a CT, but honestly, radiographs are fine. Again, older cats, so hematology and a biochemistry is also a good idea because they often have comorbidities. So on the table on the left on the screen is the staging scheme. So again, it's modified from the World Health Organization ones for women. So it's similar to the Canine scheme, it's modified from one used in people. It's stages 1 to 4. The staging goes up as the tumor size goes up. And stage 3, what's different about this is there's 4 stages rather than dogs where there's 5. So the first couple of stages are the same, but stage 3 in cats is either a big primary tumor or any tumor with a positive lymph node, whereas stage 4 is distant metastasis. Mammary, we're mostly talking about carcinomas because they're vastly more common in cats. You do very rarely get mammary sarcomas, and you can't use this scheme for that. So, sorry, Henry. So the main treatment for feline mammary carcinomas is surgery, which Henry will talk about soon because he's much better at that than I am. Okay, I'm just going to very briefly mention desmopressin because it became trendy a little while ago. It's not a bad picture. You can get your own back. It's fine. So desmopressin, there's been a few papers about that, both in dogs and cats recently. Essentially, it's antidiuretic hormone. There's been, I think it became trendy in people for a while too. It was thought to reduce circulating tumor cells and tumor thrombi if given perioperatively. There's some evidence of efficacy in mice. The results in dogs are conflicting. There was one study that showed it might have benefit, but a more recent study has shown there's no benefit. There is no evidence for benefit in cats, and we don't recommend using it. Okay. Grading feline mammary tumors is a little bit complicated because there's about 5 different schemes and there's no consensus on which one you should use. So the most commonly used scheme was adapted from the grading scheme for human breast cancer and is based on pleomorphism, tubule formation, and mitotic count. Unfortunately, this original scheme is quite prone to subjective interpretation, and because of this, studies don't always agree with the prognosis based on the grade. Because of this, there's been quite a few studies trying to make a more accurate scheme, and some of them have succeeded in that, but there's no consensus amongst the pathologists about which one should be used. So it does unfortunately depend on your individual pathology and your individual lab. All of the schemes use 3 different grades, and the vast majority of feline mammary tumours are unfortunately the higher grades. They're usually grade 2 or 3. Grade 1 is unfortunately uncommon. So while there is definitely a strong association between the grade of the tumour and the prognosis, it is a little bit dependent on the scheme that was used because some of them are more subjective than others. In a couple of studies, grade 1 tumours had a 0% risk of death, whereas grade 2 had about a 42% risk, and grade 3 had 100% risk of death at 1 year postoperatively. And in a different study, cats with a grade 3 mammary carcinoma had an average survival of about 6 months, whilst cats with grade 1 tumours had survival of 36 months. Grade 2 was somewhere in the middle. Again, it varies a bit depending on which study you read. Grade 1 is definitely good. Grade 3 is definitely bad. It's like mast cell tumours. Grade 2 falls in the middle of it. Okay, so surgery, like our dogs, surgery is a preferred primary treatment method, which Henry's going to talk about shortly. We do more frequently recommend adjunctive chemotherapy for our cats because of their much more frequent aggressive behaviour and their high metastatic rate. The one time this is a little bit not so clear cut is if you have a small tumour and you do an aggressive surgery. Sometimes they do quite well with just surgery alone. But if you have a large tumour or you have metastatic disease, either regionally or distantly, we definitely recommend chemotherapy. Again, not as many studies there are in dogs. Almost all chemotherapy for mammary tumours in cats is doxorubicin based. There has been a study that showed an average survival of 400 days for cats treated with unilateral mastectomy alone versus 1,998 days plus chemotherapy. But it's, as always, these studies are prone to bias. It depends on the inclusion criteria and whether they're metastatic, and there's a lot of it depends. The table on the left, I borrowed from a book, but it's a bit of a nice summary about the evidence levels that we have for chemotherapy in mammary tumours in cats. Yes, definitely if they are big or metastatic. If they're small and they do wide surgery, the answer is maybe it depends. Okay, so going into prognostic factors. So again, don't have as much data as we do in dogs. And the studies that we do have tend to be randomized and not randomized and underpowered. The one thing that has consistently shown up as being prognostically important is the tumor size. Staging isn't always included in the retrospective studies that we have, because again, they're often retrospective. They don't often have, whether it was metastatic at the time or the size of the tumor, because they're looking back in the medical records. Because of this, while staging is sometimes included in the studies do also sometimes just use tumor size or lymph node status as separate factors. So in the large, slightly scary table on the right that I borrowed from a paper, it's actually quite a nice paper. Actually, it's Sapuli. It's 2015. It's one of the Vet Path papers. It's actually quite a nice summary of the prognostic factors in cats. So you can see, if I stop doing that, there we go. So you can see up the top that there has been some studies looking at staging, and despite the fact that the data is not always great, there does seem to be some significance of that as well. So tumor size, like we were talking about, definitely has been shown to have prognostic significance. The cutoffs do vary a little between paper to paper, which is not especially helpful. But the three broad categories that they tend to use tend to be less than 2 centimeters in diameter, or less than 8 centimeters cubed, same thing, between 2 to 3 centimeters in diameter, or between 8 to 27 centimeters cubed, and larger than 3 centimeters in diameter, or larger than 27 centimeters cubed. Cats with small, so less than 2 centimeter tumors, can often be treated effectively with surgery alone, but by surgery we mean aggressive surgery, and Henry will go into that as well. They can have a median survival time of up to 3 years, whereas cats with tumors greater than 3 centimeters have a median survival time of only 6 months. Cats with 2 to 3 centimeters diameter tumors, unsurprisingly, sit in the middle, average survival of about 2 years. Okay, bit more on prognostic factors because it was a lot for one slide. So surgical dose recommended for treating mammary feline tumors. Henry's going to go through this as well, but it's much clearer cut than it is in dogs, and it's prognostically significant. Doing radical surgery in cats gives them much, much, much better outcomes. Even if they only have a single tumor, just because they're so prone to multiple tumors and they're so prone to developing further ones in the future. Costas was talking about spaying. We don't have good data that spaying makes any difference in cats, probably because their tumors are hormone receptor negative. By the time they've developed tumors and you spay them, the damage is already done. So it doesn't mean not to, but it won't help. So that's why we recommend more aggressive surgery, because unfortunately they are definitely prone to getting more, and the tumors they do get are more aggressive. So cats treated with radical surgery, so unilateral or bilateral chain mastectomy, have a significantly statistically improvement in disease-free interval and overall survival time as compared to cats treated with more conservative surgeries. There has also been a more recent study that shows that cats treated with a bilateral mastectomy, either at the same time or staged, have a better prognosis than cats treated with a unilateral mastectomy. In that study, there was an overall survival time of 542 days for cats treated with bilateral mastectomy versus 289 days for cats that were treated only with unilateral. In the multivariable analysis of that study, the disease-specific rate of death was greater for those cats treated with a unilateral mastectomy and those that developed metastasis. So grading, we've talked about a little bit already. It does help predict survival in our cats. Again, being looked at in several studies, does vary a little bit on what scheme they use. We do know that grade 1 tumors, although unfortunately rare, do much better. And the grade 3 tumours are almost always terrible, and they have an average survival of about 6 months. The tricky thing is those grade 2 tumours in the middle. Again, it's a bit like mast cell tumours. Some of them do okay, some of them don't, which is why they're looking at the newer grading schemes to try and get more accurate information about which ones are likely to behave more nastily. Again, with chemotherapy, the answer is sometimes. If with a small, simple tumour treated with an aggressive surgery, often they do okay with surgery alone. But your larger tumours or your metastatic tumours do have improved prognosis if you treat them with chemotherapy as well. Oops. Sorry. Oh, there we go. There we go. Okay, so prognosis depends on all of the factors that we've already mentioned. The average survival time is 12 months, but it varies massively based on all of the factors that we've already talked about, based on the tumour size. Lymph node metastasis is really important. If they've got lymph node invasion, they definitely do worse. So yes, while the average is 12, there's definitely quite a wide range, and it's very dependent on the size of the tumour and the other prognostic factors that we talked about. The table on the left is another one that I borrowed from a paper that again looks at clinical pathological criteria with respect to survival time and disease-specific survival. Again, it's a nice summary. It's a very busy table, but it does go through the different studies and what they've looked at. Okay, so brief summary. Mammary tumours are the third most common tumour in cats. There is a strong association with hormone exposure, either in entire females or those with spayed later in life. They are unfortunately almost always malignant. 85 to 90% of them are malignant, and they do tend to have an aggressive biological behaviour, high rates of local recurrence, high rates of multiple tumours, high rates of metastasis, unfortunately, so staging is important. Radical surgery is always indicated if it's possible, if they've not so far progressed that surgery is no longer possible, and chemotherapy is indicated if the tumour is large and or metastatic. Okay, thank you. Do we have any questions? Sure. Hi. Yeah, you'd need ultrasound guidance. I smile very nicely at our images and I ask them. Yes, if they're easier to feel in a cat than they are in a dog, but if they're not enlarged, it's not the world's easiest thing to do. You will probably need some ultrasound guidance. No problems. But yeah, it is unfortunately important because the rates of metastasis is huge. Okay. Thank you. I think you're going to have all the questions.
Does anybody need a 5-minute break, or shall we crack on?
Do you want presenter review? Yeah.
No, I don't need.
You don't need it. No, you can just do it. Yeah.
I haven't got any notes.
Some of us made notes. I don't remember this whole thing without the notes.
So thank you to my oncology colleagues. Both Kostas and Danielle have mentioned Scandinavia, and actually I lived in Norway for 3 years, so used to operate a lot of these. And I suddenly wished I had taken my photographs of them at the time when I was preparing this lecture. Realized I didn't have a lot of photos and had to borrow some from colleagues. But it's good to be in a country where we don't see these quite as often as in Scandinavia, so that's nice. Just a quick couple of slides. Surgery lectures always like to start with the anatomy, just as a reminder of what you might meet and what you should try not to damage, maybe. Not so much in this type of surgery. So the main blood supply to the mammary chain is from caudal. We've got the caudal superficial epigastric artery, which is probably the biggest. And then from cranial, we have some smaller branches of the cranial superficial epigastric artery, but also some perforating branches from the internal thoracic artery, so that come through the chest wall and out and supply the more cranial complexes. The lymph nodes we can do quickly because Kostas has already spoken about them. Caudally, the inguinal lymph node is very close to the caudal superficial epigastric artery, and usually actually comes out automatically when you're removing the fifth complex. The axillary artery is a bit more tricky to find. It's kind of hidden behind the pectoral muscle. I've actually not had to remove one at the same time as a mammary tumor, and so I don't have any pictures of that actually. But usually we would only remove it if it's been shown to be metastatic, and then you actually have to actively go and look for it, or if it's enlarged. So I would follow the guidance of what my colleagues tell me. If they increasingly ask us to remove more and more lymph nodes. There's also one on the picture here, which I just wanted to name as well, which is the sternal lymph nodes. So there can be apparently some lymphatic drainage to the sternal lymph node. That's not one, obviously, that we would routinely remove at the same time as a mammary tumor. So Danielle's touched a little bit on this already. So the question we have to ask ourselves in these cases is how much surgery is needed in this case. So in dogs, we have a choice of various doses of surgery or various procedures that we can do, and we'll discuss these a little bit more in detail. So either a nodulectomy or a lumpectomy, or we can go a little bit bigger and do a mastectomy, or we can remove several complexes, which would be called a regional mastectomy, or we can remove all the complexes on one side, which we would call a radical mastectomy. And in cats, we know Danielle has made the case very strongly that because tumors in cats tend to be much more aggressive, then our surgery needs to be more aggressive as well. And in cats, we really only should be doing radical mastectomies, and we'll come back to cats a little bit again at the end of the presentation. In dogs, how much surgery? So we'll go through each of these procedures one by one. Early publications told us that it made no difference. I mean, that the extent of surgery was not associated with the survival time or with the recurrence rate. There's a more recent paper from 2008, not very recent, but more recent than the earlier publications, that found that in dogs that had regional mastectomies, 58% developed tumors in the mammary tissue that was left behind. However, this is a typical case of where you probably need to read the whole paper in detail. All these bitches included in this study had to remain intact. That was an inclusion criteria. So we don't know to what extent that may have influenced the outcome in this study. And also, this study doesn't give us any evidence regarding the survival rate. So it could be that you remove a tumor once with a lumpectomy, and then the dog develops another tumor, and you could do another lumpectomy, and the survival of the dog is just as good as if you had done a complete mastectomy to start with. So how do we decide? So usually nodulectomies would be defined as a procedure that we use for smaller superficial masses where we use a smaller margin. In fact, I've put these arrows between the first two lines of the table because for me, there isn't really a distinction there. It's pretty much a continuum. So you have smaller masses, you take smaller margins, you have bigger masses, you take bigger margins. But considering a complex as one complex and being careful to remove only that complex is not something that we take into consideration, really. So what we're doing is taking the lump plus a margin, and that the width of that margin will depend on the size of the lump, really. So for me, those two first lines are the same thing. When do we decide to do a regional mastectomy? It could be for larger masses or masses where we suspect that there might have been metastatic, lymphatic metastatic spread, for instance, or if we have multiple masses in different adjacent complexes. And then the complete mastectomy is the same as if we have multiple masses in all the different complexes on one side, then it makes sense to remove the whole chain on that side. If we need to remove both chains in dogs, certainly I would usually decide to do a staged procedure, because otherwise it is a very big procedure for the dog, and usually wait anything between 3 and 6 weeks between the two operations. And then I'll just show a few pictures later on. It's not really a different dose of surgery, but it's a particular situation where it can be a bit tricky from a point of view of reconstruction. That's if you have to remove the 4th and 5th complexes on both sides at the same time. So we'll go through that. Both Kostas and Daniel have told us a little bit about ovarioectomy, ovariohysterectomy at the time of surgery, and that we don't think it really helps, but it's a conversation that I do have, certainly with dog owners before proceeding, because there are conflicting reports, so we don't know if it does make a difference to the survival. As Kostas was telling us, it may help prevent new tumors in certain dogs, depending on the pathogenesis and the pathway for these tumors. And it could also help making it easier for the owner to detect new tumors sooner, due to the fact that the ovarioectomy or ovariohysterectomy will lead to an atrophy of the mammary tissue. So if there are new tumors, they might be able to feel them sooner, so you can then intervene sooner. But it's a discussion I have with the owner, and I explain this to them, and basically they then decide whether they want us to do this at the same time or not. Right, so let's go now to the photographic section of the presentation. So first, a few images of a nodulectomy or a single mastectomy. As I was saying, it depends on the size of the tumor. So I'm a big fan of using these sterile pens for all these cutaneous masses, because it enables you to measure the margin that you're going to use, mark where you're going to do your incision, because if you don't have a line there, the moment you do your incision, the skin contracts and you kind of lose your bearings a little bit. So you can get these pens with a ruler in a sterile packaging, so you use them once the patient's been completely draped. So what we've done here, we've marked the perimeter of the tumor itself. So where you feel the edge of the mass, you make your line, then you measure this is quite a wide margin we're taking here, nearly 3 centimeters. Measure your margin all around, and then mark your line where you're going to make your incision. Usually try to see how the tension lines of the skin are and make it a little bit elliptical so that it looks a bit nicer when you've stitched it. And then perform your incision, dissect through the subcut down to the fascia. And then when we reach, in order to ensure we're getting a deep margin, we try to remove a portion of fascia underneath the location where the lump itself is. So about now, you'd want to make an incision, either using scissors, usually using scissors, in fact, into the fascia. And then, oops, sorry, that went a bit too quickly. So you can see here how we're cutting. You can see the muscle. Sometimes if it's an area where you've got a very thin muscle, like the external abdominal oblique, you can remove the whole muscle, actually. So now we've removed our mass. There's a little gap in the fascia there. You don't have to close it, but if there's not too much tension, usually I put a few stitches in there like this, and then straightforward, we close the subcut and then close the skin. So in these mammary tumors, we nearly always have enough skin to perform a wide excision like that. So that's why I was saying you might as well always do that regardless of how aggressive the tumor is. So you don't really need that biopsy beforehand. If it was an area where we didn't have a lot of skin and might need to plan for a reconstruction procedure with flaps, then it helps to know beforehand that you need to do that.
About trying to find those lymph nodes that are tucked away somewhere and you never see them.
Yeah.
Go looking for them if you've got.
So the next step up, if we want, is the regional mastectomy. So in this case, 1, 2, 3, but here without removing the lymph node. His was quite a large mass in the third mammary complex. Again, you can see we've marked the circumference of the lump itself and then calculated our margin around and marked the site of the incision. So here's the incision through the skin and through the subcut tissue. And oops, sorry, I went a bit too quickly again. So again, here we're going to dissect underneath the fascia, take a facial layer underneath the mass, particularly where the lump itself is located. And this is what it looks like after we've removed everything. And the area where the fascia or where the muscle was removed has been sutured here again. And then the skin is, or the subcut and the skin is closed. You can see here we've used a, had the name here, a indwelling, Vasilia, help me. Wound diffusion catheter. Sorry. A wound diffusion catheter, which comes in different lengths. So for these operations with fairly long scars, it's a good way of providing analgesia to these patients after the operation. Basically, you just place the catheter. It's a catheter of various lengths with little holes along the length, and if you inject local anesthetic through there several times a day, it kind of diffuses into the skin or under the skin and can provide good analgesia. So I have another example of a regional mastectomy. In this case, it was 3, 4, and 5. Actually, it was 2, 3, 4, and 5. This was a case of my colleague Esteban, so I'm not quite sure why they decided to remove the second one as well, but it could have been that there was a little mass in the second complex, as well as the main mass, which was in the third complex there. And again, everything's been marked. The tumor itself and the incision. So make the incision through the skin, through the subcut. And here you can see how a thin layer of muscle is being elevated, again, in order to obtain that deep margin, just because those cancer cells usually find it quite difficult to penetrate through the fascia. So it offers us a sort of barrier against the invasion of cancer cells into the deeper tissues. Since this is the caudal complexes, so we encounter at the more caudal end of our dissection here, we encounter the caudal superficial epigastric artery coming out of the inguinal canal. That has to be ligated because it's quite a big vessel. There, it's all done, and that wound can be closed. Now we jump to something different. So this is this situation that I mentioned earlier, where it can present a challenge for reconstruction if you have to remove the fourth and fifth complexes on both sides at the same time, because you just don't have enough skin to close. Now, you may have seen that this isn't a living dog. This was a series of images that we took for a practical course on skin flaps. So these are photographs of a cadaver, but to demonstrate the technique. So the skin that we use to close this is the skin of the inguinal skin fold. So the inguinal skin fold is that extra skin, if you want, that goes from more or less from, depends on the breed, but more or less from the patella to the abdominal wall. So the way this works is because you've got the skin is in 2 layers here. You've got 2 layers of skin here, 2 layers of skin there. So we've got all that extra skin. So you can make your incision here along the dotted line and on the other side of the skin, and the same thing here and on the other side. And that way you can gain a skin flap here, which is fairly broad based. And so this is your skin flap, and the skin on the limbs is going to be stitched. So you're kind of tightening the dog's trousers, as it were. We've got one flap on one side. You need to make sure that you dissect your flap deep enough under the subcut so that you don't damage the blood supply. And then you can kind of pull it over. So you've got one flap on one side, then we perform the same procedure on the other side. You can pull those both those flaps over, and they meet in the middle. You can put some drains in there to counteract the effect or to prevent the complications of having so much dead space there. And then this is after the subcutaneous tissues have been sutured together, and this is after full closure. So you can see here where previously the dog had the skin fold here, it's now all just follows the muscles and the body wall. This is what it looks like from the side. And I've just borrowed a picture of an actual patient here, but that's taken from a surgical oncology book, where they've really been quite aggressive, it seems. They even seem to remove part of the vulva from what I see there. But you can see how recruiting that skin from the skin folds has enabled them to reconstruct this completely. Right, finally, complete mastectomy, which, as we've discussed, is what we would always use in cats. So we can do this as a unilateral procedure or a staged bilateral procedure. So a unilateral followed by another unilateral, or we can do this as a bilateral procedure in one go. If we do it as a bilateral procedure in one go, then certainly on the cranial end, here it's less essential, but on the cranial end, you need to preserve some skin between the two mammary chains in order to close. Otherwise, you're going to really struggle to close the skin up there on the cranial part of the chest. So this is something that Daniel has mentioned already. So we know that bilateral cats that have bilateral mastectomies have a better survival, so there's a better outcome. They live longer than cats that only have a removal of one mammary chain. And the staged procedure will have less complications. So you do have more complications from a surgical perspective if you try to remove both in one go. So I have an example here of a cat that probably has quite a poor prognosis from what Danielle told us, because this is a very large tumor, almost crossing over the midline. So there was really only one option in this cat, and that was to do a bilateral simultaneous mastectomy, total mastectomy. So yeah, don't be a bit confused by the lines here, but so we are going to preserve this skin. This is cranial, by the way, that's caudal. So we are going to preserve this skin on the cranial edge of the thorax so that we can close and end up with a Y-shaped incision. This is kind of similar to the regional mastectomy, but I wanted to show one distinction here, which is that I find this helpful actually if you're going to remove an entire mammary strip, or if you're removing several complexes caudally, is actually to start your dissection caudally and start by looking for that larger caudal superficial epigastric artery. And if you start by ligating that vessel, you'll have a lot less bleeding to deal with during the rest of your dissection. So this is what we're doing here. This is the first vessel, which is ligated. Oops, went too quickly, but it's not essential. And then the second one, and then there's the second one. And then once we've ligated both, we can quite easily perform our dissection right on the fascia from caudal to cranial. There's much less bleeding along the edges. But here, this is a big tumor. Here again, we need to obtain some deeper margins underneath the tumor. So we remove the fascia. In some cases, if needed, we can remove the whole abdominal wall. It looks like that was the case here. And then that obviously needs to be closed, which we've done here. And then the skin is closed as well. And again, so you can see here this Y-shaped incision preserving skin over the chest, because otherwise you wouldn't be able to close without tension. And that brings me to the end of that quick little overview of surgery for mammary tumors. Happy to take any questions. Any questions for my colleagues as well?
First of all, it's left on something afterwards. How long do you maintain that fusion catheter on?
So I would leave it in not more than 2 days, because we don't want is that balance between providing good analgesia, but it also means that the cat in this case, or the dog, needs to stay in hospital a little bit longer. So we don't want to keep them in hospital longer than necessary. So I would say the average is we pull the catheter maybe at the end of the second day and then send them home. And then the protocol, I think, provided we use something that's long acting, then you can give it sort of every 8 hours or something like that.
If you all enjoyed it, I hope it was useful. I certainly enjoyed it. Well done. Thank you very much to our speakers of tonight, Costas, Danielle and Henry. For people who refer to Southfields, I was going to ask a little favour. I've got this fancy little QR code, but it gives a link to a feedback survey about Southfields. So I would be very grateful and appreciate your feedback if anyone has got any experience with referring to Southfields. With regards to CPD, I'd also welcome your feedback, you know, obviously on tonight's presentation, but for future reference, if you guys wanted to hear more on a certain subject or less, then feel free to contact me via the same email as I contacted you for tonight. Should you have any more questions for our speakers on the subject, I'm sure they will agree with me that you can contact them at any time. You can do that directly to their discipline inbox, but the vet hub that we've got on our website is also very useful for any advice requests, should that be on tonight or any of your cases that may concern discipline. We will be back in June, potentially in May. We've got a date burning there that we might do another CPD. But that's it for tonight. Feel free to socialise with each other and our clinician. There's some food and drinks left at the back, and otherwise enjoy your evening. Thank you. Yeah. Yes, in May. I've got to go.
Actually, yeah, I've got a lecture on that. It's quite a short one though.